Okay, guys, going to start on chapter 23, part 1, digestive system, otherwise referred to as the gastrointestinal tract or GI tract. Okay, let me get my pen to draw with, and there it is. Okay, a little bit of overview on this. The GI tract, this slide really should have went uh, a little later on in the PowerPoint, but it's here where it is, so let's go with it. The GI tract is where we're going to take in food. We're going to break it down, get everything that we need from the food, and then get rid of the rest. We break food down mechanically and chemically. Mechanically with things like teeth and slamming the food around in our stomach. Chemical digestion, we're going to break down our nutrients. That's the stuff that we actually need from our food. We're going to break it down with hydrolysis reactions. You guys remember way back to AMP1 where we talked about hydrolysis, where you add water so that you have a situation like this. These guys are bound together. Well, we're going to add water, but these guys are bound together by an oxygen. And these are the subunits that make up all the different types of food. When we add this HOH, this H is going to go with the oxygen, the OH is going to go with this, and it's going to separate it, hydrolysis reaction. We also talked about dehydration synthesis, but all we care about now is the hydrolysis. How exactly we totally process this, our digestion, is going to depend on the structure. Carbohydrates, which are chains of sugars, triglycerides, which are fats, proteins, are shaped differently and have different groups attached to them, and so they go through a slightly different process. pH. The pH is important for some enzymes, only work when the pH is very low. In other words, when it's a very acidic situation. And that's especially true for this stuff in their stomach right here. We have very low pH, and it's going to cause some of the chemical hormones, not hormones, but enzymes to be activated by the low pH. Modes of membrane transport, which is basically, if this is the GI wall, this is how we get the nutrients out of the lumen of the GI tract and into the inside of the body, predominantly, of course, going to either blood vessels or in some cases lymphatic vessels. This is a pretty good little model of the GI tract, kind of plasticky, but apparently it's supposed to be like that. That's the esophagus, the tube that leads from the mouth. Here's the stomach. This is the liver, which is actually a big player in this. After the food leaves the stomach, it's going to go through the small bowel, the small intestine. This is where most of the absorption of nutrients and some water is going to take place. But the end of the small bowel is going to attach to the colon. And by the way, there's the appendix. And the food, or not the food anymore, it's actually the waste material, will be moved through the colon in this direction, and it will be stored in the rectum until it's convenient for us to get rid of them out of our bodies through the anus right there. Each organ is very specific, and each one is very important. And the digestive system is going to work hand in glove with the cardiovascular. I showed you the drawing with the blood vessels. The blood vessels are going to transport the absorbed nutrients And if you guys remember back from the blood vessels we talked about, the hepatic portal vein, most all of that is going to the liver first before it goes anywhere else. Endocrine system, some of the hormones that are involved in moving things along. As far as general anatomy, we kind of went over a little bit of it. You're going to be covering this in your lab class, so I don't want to spend a lot of time. So the teeth, of course, the tongue, the mouth, and then the pharynx, which is another name for throat. There's that esophagus. There's our stomach. It's kind of partially hidden by the liver. The small bowel, the colon, the rectum, all of that. Uh, the digestive tract is basically one big long tube that starts here and ends here. Yeah, I know it's kind of twisted and turned and everything, and then the stomach is actually kind of dilated a little bit. Here's the stomach. But basically, essentially, it's just one big long tube. This is oftentimes called the alimentary canal. Muscular tube runs from the mouth to the anus. In a living person, this tube is about 25 feet long. And of course, when a person passes, the muscle tone is lost, so it actually gets a little longer at 35 feet. Mouth, pharynx, esophagus, we already talked about all that. Now, these accessory organs are not part of the tube, but they are vital components in helping us to get our food processed. The teeth, for one, the teeth are going to do part of that mechanical digestion I talked about. They're going to actually cut and grind the food up into smaller particles. The tongue is going to move the food around the mouth. It's going to mash the food against the top of the palate when we're getting ready to form that little ball that we actually swallow, called a bolus. The liver, and we'll talk about it first, is going to make bile, and of course it's going to be the destination for all the absorbed nutrients. The bile that the liver makes is going to be stored in the gallbladder. The pancreas, which you really can't see, is going to be behind everything here. The pancreas is going to actually have the enzymes that chemically break down all the foods. We'll talk about this in much detail during this chapter. And these accessory organs are totally out of order, but salivary glands are around the mouth, the parotid, the submandibular, and the sublingual. These guys produce saliva, which helps to moisten the food, which helps us to get it into that nice compact bolus. That's the name of that little football-shaped ball that we actually swallow and send down to the stomach. There's more to it than that, but we're just doing an overview right now. Okay, the GI tract, the tube itself, these guys are going to have layers. You're going to talk about this in the lab class as well. But let's start talking about it, and the next slide actually goes into better detail. The mucosa is going to be the innermost part. Let me see right there. So depending on which part, this looks like to be this is the esophagus. That's the diaphragm right there. So this is the thorax and this is the abdomen. But in any case, the innermost layer is going to be epithelium. It's going to be stratified squamous epithelium because it's going to be subject to some friction. It changes to columnar, simple columnar, a little bit further down. We'll talk about that too. Underneath the stratified, of course, we're going to have the lamina propria, which is basically going to be our basal membrane. Underneath that, we've got a muscle layer. I don't know if you guys can see it. It's really tiny right there. That's going to be the muscularis mucosae. all that means is the muscle layer of the mucosa. So underneath the mucosa, you have the submucosa. The submucosa, right there, see there's the muscularis mucosae. So underneath that, we're going to have the submucosal layer, and underneath this submucosal layer, although they probably consider it to be part of the same, we have two muscle layers. One is a circular, so in other words, I've got one that actually runs this way around the tube, and then I've got one that runs this way. That's just the way the muscle fibers. Let's see if I can do this, guys. It's kind of hard to draw with this. So these muscle layers are running like this. So when they contract, they're going to like squeeze, and on top of them is another muscle layer. And remember, this is smooth muscle, guys. That's going, let's see if I can get that cigar shaped nuclei. It's going to run the longitudinal. So the inner layer is a circular layer, the outer layer is longitudinal. On the models you see in the lab, you'll be able to tell that. Let's see if I can try. I can barely do this. Okay, so the muscularis externa has two layers. On the outside of that is serosa. Serosa is kind of another name. It's a connective tissue layer that's there that kind of holds everything together. Now let's see, if you look over here, you can see some of this. So there's these. There is the epithelium. That right there is going to be our basal membrane. It's kind of hard to see on this because the muscle layer is so tiny. Here's something else that we need. There's that longitudinal muscle layer. You can see it very well there. And you can see this one going this way. There's a circular. Between these two, we have a layer of nerves. Muscles require nerves to activate them. This nervous system that's part of the GI tract is called the enteric nervous system. This particular one is between the two layers of the muscularis externa. It's called the myenteric plexus. Now, on the submucosa, between the submucosa and the muscularis externa, we've got, or the, it would be the submucosa. Between the submucosa and the muscularis mucosae, we've got another part of that nervous system called the submucosal plexus. It's just nerves. You can see them, the yellow right there. Continuing on, guys. This is a really good picture. I really like this one. You can see a lot of it. Let me kind of divide this up so we can keep these guys straight. Simple columnar, most areas stratified squamous from the mouth to the esophagus. There's a lot of lymphatic nodes. We talked about this when we did the immune system. These are called mucosa-associated lymph tissue, or MALT, because we're taking things in from the outside of our body. Very real potential that bad guys are going to get your ride. So we have a lot of lymphoid tissue that stands guard to make sure those bad guys do not get on the inside of our body where they can cause trouble. I'm not going to try to explain it to you, but the inside of the GI tract is not inside the body. It's a tube. Outside that tube, that's the inside of your body. But in any case, you can see everything here. Let's see, the epithelium, lamina, muscularis mucosae, right there. this layer right there. This is much better, I think. Oh, you can see the circular layer really well. You can see how these fibers are running this way. Um, you see the myenteric and the submucosal plexi. So, and of course, obviously, you got to have nerves that are feeding into these plexi. You've got arteries and veins and lymphatic vessels because we've got to supply blood and take out waste material and all that. Submucosa. So the mucosa is basically epithelium with a basement membrane with a layer of muscle around it. The submucosa is connective tissue that has blood and lymph. There's our blood and lymph vessels, nerve plexi, and the glands. The muscularis, we've talked about, muscularis externa. And the serosa is just a relar connective tissue with simple squamous epithelium. And this is going to be a lining kind of thing. The enteric nervous system, we've already kind of touched on that. And a lot of nerves. It's part of the autonomic nervous system. That's back from AMP1. This guy is going to regulate motility, which is the activation of the muscles. It's also going to have a lot to say in the secretion of chemicals and with the actual flow of blood through this system. Remember that back from AMP1, that when the sympathetic nervous system takes over, we shunt blood away from the GI tract because in the event of a life-threatening emergency, we can spare the time. We can do our digestion later. The submucosal, you don't have to know the name. I'm not going to require that because we're getting away from that. Submucosal is going to control the muscularis, mucosa, and some of the glands there. The myenteric is control of peristalsis and segmentation, which is going to be the muscularis externa. I'll let you guys read that. It's kind of interesting. Not the best one I've seen, but it's okay. So we have two kinds of responses in this nervous system. We have one that's called a long reflex and one that's called a short reflex. By long, we mean that a stretch, the mechanoreceptors, a particular type of chemical, or a particular change in concentration is going to cause a signal to be sent. Now the short reflex, that signal is basically local. This guy is going to report this to that nerve plexi that is in the myenteric plexus, and then this guy is going to control the smooth muscles or glands to do it. So what am I talking about? I'm talking about when your stomach stretches, when food gets in, that's going to be the signal for the stomach to start doing its job, which is basically squeezing and kind of slamming the food back and forth and making it. Now that's the short reflex. We also have the long reflex, where this information is sent to the brain. That's why we call it long, because it's going to leave the GI tract and go all the way to the brain. And then the brain is going to send out its orders to the myenteric plexus as well. Here's something that's the internal stimuli, which is basically stretch or something like that. A lot of stretch in the GI tract, but our GI tracts will actually start working anytime we see or smell or taste or even think of food. If we're hungry, if you're hungry and you start thinking about lunch or dinner coming and you can hardly wait and all this, then that's actually your mouth watering That's the salivary glands beginning the process, and the same thing is going to happen down here inside the GI tract. Peritoneum, again, way back from A&P1, we know we have different covers that cover our cavities and the organs in those cavities. So we have one for the cardiac, we have one for the pleura in the lungs, and we also had one, if you recall, called the peritoneum. The peritoneum is going to line the abdominal pelvic cavity. The parietal peritoneum, the visceral peritoneum is actually going to line the organs in there. There's the liver and the stomach. This is part of the colon, the transverse. These are loops of the small bowel. Now, not every part of the GI tract is actually in the abdomen, believe it or not. Some of it is behind the peritoneum. It's called retroperitoneal. Part of what the peritoneum does is tacks the bowels to the back wall of the abdominal cavity. This keeps these guys in place because otherwise, when we ran or walked or anything, the internal organs would all wind up, piled up down here, which would be ridiculous, and not to mention non-functional. So this is part of what they do, is help them stay in their place. Now we also have a special type of the peritoneum called mesenteries. These are pretty thick connective tissue sheaths. We have a lesser omentum. This is going to tack the top of the stomach to the bottom of the liver. Then we have a greater omentum. This guy is actually going to fall over the front of the small bowel like an apron, and of course it's going to attach to the bottom of the colon. The bottom of the stomach falls over like an apron or a curtain, and then attached to the bottom of the colon. These things are connective tissues. They have nerves and blood and lymph vessels and big globs of fat. It looks like a fatty apron. That's what it actually looks like. There's our omentum there. Mesenteries are going to be, see if I can draw all this. You're going to be able to see this a lot better on the lab. The mesenteries are going to be that part of the peritoneum that actually connect these guys to the back wall. It's kind of hard to see, especially on the small bowel, because it kind of loops out. But that's what the mesenteries are. That's what the omenta are. And we already talked about the peritoneum. These things, this is a good illustration, but it's really hard to see. So you really are going to need to look at the models in the labs, and you'll be able to see all of these structures. The peritoneal layers, again, we've got a parietal, which is attached to the walls of the cavity. We have a visceral, which is attached to the organs. And in between, we have a space. It's not a real big space. It's more what they call a potential space. It's lined with fluid, just like in the lungs and in a heart. Because these organs do move, even though they're tacked to the back wall, they do movement. And so in order to maintain a frictionless environment, we have that there. Digestive process. Steps are ingestion, we take it into the mouth. Propulsion, we swallow it and move it. Now propulsion, you may have thought, well, the food just falls by gravity down our esophagus. And actually it doesn't. It's squeezed all the way through. So that's why you can actually swallow upside down. because we're not dependent on gravity. Mechanical digestion, which starts in the mouth with the teeth. Chemical digestion also starts in the mouth. We actually release a chemical to help breaking down carbohydrates. We'll talk about that. Mechanical and chemical digestion continues in the stomach, and in the small bowel we have a lot of chemical digestion, and we also have the absorption. That's where we get the parts of the food that we need and we take it inside. We transport it through the wall and put it into the blood or the lymph node. Finally, we have the elimination, defecation of all that we don't need, if we've already taken everything that we have any possible use for. So as far as propulsion, the swallowing, the oropharynx, the tongue kind of goes from here, kind of lifts up and forms almost like a little slide. And this is the back of the mouth and the esophagus, and it goes down. And again, these guys are going to squeeze it down. Peristalsis, that's what we're talking about, the squeezing action. The esophagus, stomach, small bowel, and colon are all going to do peristalsis. There's also something we talked about earlier, segmentation, and I'll get to that in just a few slides, guys. Chemical digestion is using chemicals to break molecular bonds so that we can take a big carbohydrate and cut it up into individual sugars so that we can absorb those sugars individually, because that's the way we do it. Mechanical digestion, we've talked about chewing in the mouth. Churning is what they say the stomach does. It's basically the stomach just throws it slams it side to side, and eventually turns that food into kind of a creamy liquid called chyme, C-H-Y-M-E. Segmentation, I'll show you that when it's on this part of the PowerPoint. Absorption, nutrients and water in the blood and the small bowel. The colon is basically absorbing some of the water. We have to have some to lubricate the feces so that it doesn't scrape the inside of the colon. Mechanical digestion, breaking it into smaller particles. The smaller the particles. So if I have a piece of food like this, and of course it's three-dimensional, so I'm going to try to, in my own inimitable way, draw it. There's a certain amount of surface area there. Believe it or not, if I take that same thing and break it up into, say, 3 or 4, I've actually got more surface area because parts of it that are in here are now going to be exposed. That's one of the main reasons that we do that, and as well as making this thing smaller, we want to increase the surface area because that's what the chemical digestion is going to work on. It's going to, the more surface area the enzymes can reach, the faster the process goes. So the teeth cut and grind, and then the smooth muscle in the stomach and the small bowel help to do that as well. Okay, here's peristalsis. Here's what happens, guys. The circular muscle layer squeezes together. Okay, it relaxes in front. Now these guys are also, the longitudinal muscle layers are going to contract, and what that's going to do is it's going to push this guy over here, and when he gets there, then this layer is going to contract and this layer is going to relax, and when he gets down here, then the same thing. That's peristalsis. This is, we're using the circular and the longitudinal muscle layers, contraction and relaxation. Contraction behind, the longitudinal contracts in front of, because that's going to make the tube smaller. The circular is going to contract behind and that's going to propel. Now the circular layer is going to be relaxed in front, but the longitudinal is going to be contracted. I'm going to tell you guys the best way to understand this is go to YouTube and watch a video. And I'm sure we've got some videos on Blackboard that you guys can look at. It's going to be the best way to see this. Personally, in order to understand this, my little drawings just really aren't as adequate. I would look at an animation that shows it in action. Segmentation, this is what we were talking about. Now in this case, we're not actually doing peristalsis, we're not moving it, from A to B. What I'm doing is I'm moving it here, I'm moving it back, I'm moving it here. What am I doing? I'm slamming it back and forth. So 8 to 12 times a minute, common contraction, we're breaking the food particles into smaller, mixes the food with the digestive, and it increases our absorption because we keep moving the food over the same thing. Again, this is one that you really need to see. My description, as good or as bad as it is not going to equal what you can see by seeing it actually happening in action. Chemical digestion, we talked about hydrolysis. This occurs from the mouth through the small bowel. There's not really any chemical digestion after we get into the colon. We're going to take these big molecules of carbohydrates, proteins, and lipids, fats, and break them up into their building blocks. Polysaccharides, which is another name for the carbohydrates, we're going to break them up into single sugars. Starch that you get from pasta or potatoes, or a lot of, I don't know if I can draw this, a lot of glucose sugar molecules that are linked together. So we break that bond because we absorb these one sugar at a time. We don't take the whole thing in. Proteins will be broken down into amino acids. Fats, we're going to break them down into monoglycerides and into fatty acids. Nucleic acids, we're going to break them into nucleotides, A, T, C, and G. I don't think the concept should be that big of a deal. Okay, the mouth, the beginning. The oral cavity, also called the buccal cavity, because of, well, your cheeks. That's the buccal membrane. This guy is going to be the ingestion, give us our taste, but we can only taste things when we have saliva there. If you have a totally dry mouth, things aren't going to taste as well. Mastication is the act of chewing. It's the teeth tearing into the food. We're going to swallow. Some chemical digestion, there's something called salivary amylase. Salivary amylase is the chemical that starts the breaking down of carbohydrates, starts in the mouth. There's another amylase later on to finish it, but that's what it is. We also know the mouth has a role in speech. Respiration, yeah, sometimes, mostly nose, but the mouth can do a little bit on that. Okay, as far as the parts, the interior opening is going to be the oral orifice. The fauces, which is the hole at the back of the mouth, that's all it is, posterior. That's the boundary between the oral cavity and the pharynx. Inside the mouth, it's not keratinized, but it is stratified squamous epithelium, because with the food going through and everything, there's a certain amount of friction. And so we have the stratified epithelium that will actually be scraped off. Let me go through this. Upper lip, superior labial frenulum. That's that little piece of tissue that connects your upper lip to the gums. The inferior labial frenulum is right there. We also have a lingual frenulum. That's that tissue that connects the front of your tongue to the bottom of the mouth. These guys are your tonsils, the palatine tonsils. These arches here in the back are called the palatopharyngeal arches. The hard palate, and you see those ridges are called rugae. Tongue. We also have the openings for our salivary glands. You see some of them right there. That's the sublingual salivary glands. That's where the saliva comes out for the sublingual, and here's the submandibular. The ones for the parotid glands are actually back there. Mastication, mechanical, voluntary, reflexive, pattern, rhythm, stretch reflexes, receptors on the tongue, gums, and cheeks. We generally, although we can consciously control our chewing, a lot of times we just put it on autopilot, and that's where we say that it's partly reflexive. The tongue. Non-keratinized, stratified, squamous epithelium, same as in there. But these guys have little projections that come off of them called papillae. We already talked about the lingual frenulum attaching the tongue to the floor. Now the tongue has muscles to control it. Some of them are actually in the tongue itself. Those we're going to call intrinsic muscles. These guys are going to have to do with changing the shape of the tongue. And then we have extrinsic muscles like the genioglossus and hyoglossus muscle, which are going to help position the tongue in different places. Okay, there's the epiglottis. That's the dividing line between. We talked about this when we talked in the respiratory. The lingual tonsils, palatine tonsils, lingual tonsils underneath. Terminal sulcus, not really important. Valate, papillae, foliate, and fungiform. These have different functions. Not sure how much they want us to know, but now we'll find out. Much bigger picture. Filiform, these guys are the most numerous. These are not taste buds. These are going to be those little white spots on your tongue that you see. These guys provide friction, and they may enable you to lick an ice cream. Because there's a little bit of roughness to the surface of your tongue, you're able to move it off. Not anywhere near as rough as, say, a cat's tongue, which are like sandpaper, but still it gives us what we need. The keratin that stiffens them is going to cause it to be that whitish colors. Now, that's the filiform papillae. We also have these others, and these guys are going to be the actual taste buds. The fungiform, which means they're going to actually kind of be like that, like a mushroom shape. They're all over. Circumvallate, or is this V-shaped at the very back of the mouth. And on the lateral surface, I don't know if you guys can see it right there. There's the foliate. So these are taste buds. There's 5 tastes according to the latest research, but we're not going to go into that right now. The intrinsic salivary glands, these are the glands that not part of those 3 that I talked about. These guys are actually in the tissue, so they're not a separate gland. Well, they are, but they're kind of not. The lingual glands are in the tongue. The labial glands are inside the lips, and the buccal glands are inside the cheeks. These guys are going to have a small amount of saliva that they're always going to produce. And the saliva is going to contain lipase, which helps to start breaking down fats, and lysozyme. Lysozyme, I don't know if you guys remember from the the immune system, this is a chemical that punches holes in the bacterial cell walls. This is something that comes from our eyes. Our tears have lysozyme in them, and we use this, and also on our skin. We use this to kill bacteria. We don't want to bring it in. The extrinsic salivary glands, these are the ones that we were talking about prior. I showed you some of the openings. So our saliva or salivary glands are going to produce between 1 to 1.5 liters of saliva a day, a lot. Most of it's going to be reabsorbed or else we would dehydrate. The parotid glands are the ones that are going to be on your cheeks, just in front of your ears. These are the largest. There's one on either side. These are the ones that get infected when a person gets mumps. Mumps is not nearly as common because of the MMR, but still. This guy is going to produce a watery saliva. It's going to have enzymes in it. Now I'm going to jump to the sublingual. These are the smallest of the glands. They produce a saliva which is mostly kind of mucus, sticky, and slippery. And we already said they opened up. Why did I do that? Because the submandibular glands are going to produce a saliva that's somewhere between these two. They're going to have one that's both watery and mucousy. I don't know if that's a word. Mucinous would probably be a better word for that. But that's okay, guys. As far as saliva itself, it's a hypotonic fluid. It is mostly water, 95.5%. It's basically neutral in pH. Contains mucus, which is a slippery thing that gives it its lubricating abilities. There's going to be some ions in it. The lysozyme we've already talked about. IgA, we talked about that when we did the immune system. Again, it's a defensive thing because there's a lot of bacteria that enter our body through this. We talked about the two enzymes that begin chemical digestion, salivary amylase, which is going to break down the carbs, and the lingual lipase, which are going to help start the digestion of fats. We do have to remember to call this salivary amylase because there is a pancreatic amylase. There's also a pancreatic lipase. So the first part of those names are very important, especially, maybe not so much for us in a multiple choice question, but when you do this in the lab, you definitely need to make sure you know the difference between those two. What does it do? It moistens the food particle because nothing goes down like dry food. It burns your throat. It scrapes. It deals with the bacterial growth because of all that stuff. We dissolve molecules in water, which also enables us to taste because food that's not dissolved in saliva, we don't have a taste. Begins the digestion of starch and binds it together and makes a little football-shaped bolus. Okay, here are some histology, but I'm going to let you guys do that in the lab. I'm not going to have any pictures on the exam for that. Mumps, that's what it looks like. Very, very inflamed glands. This is spread by saliva. Fever, pain, especially when opening the mouth, chewing or swallowing acidic foods. And in adult males who get the mumps, there's actually a risk of the testes becoming infected and causing sterility. Okay, control of salivation. Signals go to the salivary gland from the ANS, cranial nerves 7 and 9. What triggers salivation? Food in your mouth, the smell of food, the sight of food, the thought of food. Nausea and irritations from stomach acids or spices will also cause salivation. What's going to turn it off is the sympathetic nervous system, stress, dehydration. If you're dehydrated, you don't have enough water to make a lot of saliva. but the sympathetic nervous system will turn it off and keep it to a minimum. Now, people who use crystal meth simulates the sympathetic nervous system. It simulates the fight or flight. It turns off the salivary glands, which turns off the lysozyme, which turns off the IgA, and that's one of the reasons people who do crystal meth long term will have lots of dental cavities, and they have horrible, horrible teeth because of the lack of saliva due to the use of the drug. Tooth structure, since we're talking about teeth, organs of mastication, which is basically the same as what you chew with. Okay, we have three main parts. We have the crown, which is going to be this part that shows above the gum. The gum, by the way, is called the gingiva. We have the neck, which is going to be this narrow part. It's going to join the crown to the root. The root is the area that goes into either the mandible or the maxilla in that gomphotic joint, and these periodontal ligaments and the cementum are going to hold them steadfast in there. Inside the roots, and there's the pulp, this is where the nerves are and the blood vessels. Excuse me. Crown is going to be covered by something called enamel. It's the hardest substance in our body, and if it gets damaged, it's not repaired. That's when we have dentists who charge a lot of money to repair it for us. I think that's everything on this one. We got another one on the next slide. Let's go ahead and go through there. Okay, underneath the enamel, we have something called dentin. Dentin is going to be the biggest part of the tooth. It's going to be kind of a shock absorber. And in the pulp cavity, we've already talked about on the other one. It's going to be inside connective tissue, blood, lymphatic, nerves. The guy that's going to help you appreciate your toothache. And you can see as the holes get there, and once it gets there, then you get an abscess tooth because you get an infection, you get bacteria in here. That's when the dentist will do a root canal, which means they'll actually take that root out. And depending, I think that's when they do the crowns. I'm not a dentist, so I'm kind of talking out my hat. So let me just stick to what I know. Dental caries, that's the name for a cavity. Not very nice, don't feel good. So what happens is when the bacteria will consume the food that we leave on our teeth, then they're going to take that food and they're going to process it. One of their byproducts is an acid. That's what demineralizes. It actually dissolves the minerals in the enamel and eventually wears through. Plaque is a film. It's actually some sugar, bacteria, debris. This is going to be the main source of the problem right there. This is what you'll find out later on is called a biofilm, and the bacteria inside that biofilm actually are covered with a protective coating so that stuff can't get into them. I mean, water can get in. They've got holes, and they just go to work on this. But that's why we have to go and let the dental hygienist scrape our teeth every 6 months to get this film off. If we don't, then it gets really hard and becomes something called plaque. Okay. Now, this is obvious poor brushing. I would agree. There's Again, I'm not a dentist, guys, but I'm pretty sure that's going to be plaque. But I am sure about this. Notice that those gums right there, they're not pink, they're red, they're inflamed. That's gingivitis. The bacteria have actually infected the gums. And if allowed to go long enough, you get periodontal diseases. The bacteria are going to dissolve bone and the periodontal ligaments. And notice this is where the gum line should be right there. You've actually got the neck of the tooth exposed right there. The gums have receded, and you're going to lose teeth. When the periodontal ligaments, the gomphotic joint is holding the teeth in, are gone, then the tooth has nothing to hold it in. There's a lot of expensive dental procedures to fix that, implants and so forth. Okay, pharynx. I think we talked about this during the respiratory, so this shouldn't be a whole lot. So we said the pharynx is basically your throat. The part behind the nose is the nasopharynx. The part behind the oral cavity, there's the fauces by the way, is the oral pharynx, and the part below the oral pharynx around the larynx, which is your voice box, right? And the opening to the trachea is the laryngopharynx. Whereas before we were concerned about the air tube here, and there's the epiglottis, of course. Now we're more concerned with the passage of food. We'll close the epiglottis when we swallow food, so that the food will go through into the esophagus and not into the trachea. We also, that uvula, that little guy hanging in the back, the muscular soft palate here will actually rise and close off. So when we swallow, we want to close off the area going that way. We want to close this guy, so we want to make sure the food only has one direction it can possibly go in. Can these guys get overridden? Well, sure. If you've ever had something go down the wrong pipe, is the way it's described. Or people who laugh and have milk come out their nose, which also burns. All right, that's everything on that. I think this is going to be our last slide. The esophagus. The top 1/3 of it is going to be purely skeletal muscle. The middle 1/3 is going to be, put that there, is going to be mixture of smooth muscle and skeletal muscle, and in the bottom 1/3 is going to be smooth muscle. This guy is going to be the conduit that the food is going to move down into the stomach. So he's going to be non-keratinized stratified squamous epithelium. Now there are two, let me draw it over here, guys. So there's the stomach, and here's right there. There are actually two ring-like muscles that close these guys up. There's the upper esophageal sphincter and the lower esophageal sphincter. So the upper sphincter is going to open, it's going to relax so that the bolus of food can come through. Once the food gets into the stomach, then this LES is going to shut down tight. That way, when the stomach starts churning, we won't get acid that spills up into the esophagus. If the LES does not do its job for some reason, most oftentimes it's because when we have a little bit of extra weight, we actually push the esophagus a little bit higher up into the thorax. The LES doesn't work. When that happens and the stomach does its churning, it kind of splatters acid in the esophagus. That's what we call reflux or GERD, gastroesophageal reflux disease. And that's it, guys. So I'll see you on the next PowerPoint in just a little bit.